everyone. Everyone, I hope you guys are okay. So, in Nursing 2.1, we are going to have ENT, ear, nose, and throat nursing content. That is in Nursing 2.1. That is what we're going to have right away. Definitely, at most during our, mostly in pediatrics outpatient department, realize that even the history entails the ENT, history, be it examination or whatever. So the course outline of ear, nose, and throat. First, we'll have to introduce and define ENT terminologies, which you're going to do today. A review of anatomy and physiology of the ear, function of the ear, physiology of hearing and balance. Then we'll see history taking, demographic data, history of presenting illness of the same, chief the complaints, past medical history, surgical history, and review of systems. We'll check on the assessment of the auditory system, inspection, that is direct palpation, otoscope examination, and then we shall evaluate the gross auditory activity by whispering test, Weber test, and Rhine test. We shall check on diagnostic evaluation using audiometry, tympanogram. As well, we shall test to detect vestibular problem using the Romberg test, caloric ear test stimulus, electronystomography. The name is kind of hard always to pronounce. And then later on we shall check on the hearing loss and deafness, types and classification of the hearing loss, check on the assessment of the hearing loss, clinical manifestation, early and late, check on the risk factor of hearing loss, management of the hearing loss. Going after that, we shall check on condition of external ear now. On the cerumen, or some people call it cerumen, impaction, what your auditory canal secrete, that works like substances. Yeah, still on the external ear, check on the foreign bodies, external otitis media. Then later on, go to condition of medial ear, talk about tympanic membrane perforation, acute otitis media, serous otitis media, chronic otitis media, and otosclerosis. After that, we shall check on nursing care of patient undergoing middle ear surgery. And that is very vital for a nursing student, because at most you'll even be in a special care for ENT department, or maybe ENT hospital if you specialize. So you need to get on this. After that, we check on condition of inner ear containing motion sickness, Meniere disease, labyrinthitis, and the labyrinthitis, ototoxicity. We shall check on the acoustic neuroma. Still, the nose and paranasal will come next after ear, and we'll check on the same anatomy, physiology of the nose, function of the nose, physical assessment of the nose, sinuses. Condition of the nose consists of epistasis, sinusitis, rhinitis, nasal polyps, nasal fractures, ukipigwa ngumi, deviated septum, mpwako kinaonekana iko combo. Then the throat, check on the tonsillitis, adenitis, laryngitis, for cancer of the larynx, cancer ya sauti, ama sound box, peritonsillar epiglottitis, nursing process of the partial laryngectomy. So that is that. So let's start with the terminologies. That was the key thing that we want to do today. First of all, terminology ENT first. Okay, we are going to see what is acute otitis media. Acute otitis media, inflammation of the middle ear lasting less than 6 weeks but starting immediately. Cholesteatoma. The cholesteatoma, a benign tumor of the middle ear or mastoid or both, and can destroy structure of the temporal bone. Chronic otitis media. This is a repeated episodes of acute otitis media causing irreversible tissue damage and persistent tympanic membrane perforation. Conductive hearing loss. That is loss of hearing in which effective sound transmission to the inner ear is obstructed. Dizziness. Dizziness, that is altered sensation of orientation in space. To mean that, some people say, I'm dizzy, I'm wondering. You're supposed to be like, even the orientation, you don't understand. Yeah? You're confusing a bit. That's dizziness. Okay. We have another one called Endolymphatic Eye Drops. That simply means the dilation of the endolymphatic space of the inner ear. We have another one called ectosis. Those are small, hard, bony protrusions in the lower posterior bony portion of the ear canal. Then you have labyrinthitis, inflammation of the inner ear, vertigo, an illusion of movement in which the individual or surroundings are perceived to be moving. Tinnitus, subjective perception of sound with internal origin, unwanted noises in the ear. That is called tinnitus. Ukidungwa quinine, then the side effect, say, masikio yangu inalia. My ears are, if you are having an injection from quinine, and then you are on the side effects, you get that your ears are each and every time. That is tinnitus. It's just a perception of sound, subjective, not objective, but it's a subjective, yeah. So it's a symptom where the patient is the one who is feeling it. Perception of sound with internal origin, unwanted noise in the ear, tinnitus. Then you have Meniere's disease, a condition of the inner ear characterized by a crowd of symptoms. 1, episodic vertigo, and I told you vertigo has something to do with hallucination, followed by tinnitus, fluctuations and sensorineural hearing loss. The another one is middle ear effusion or serous otitis media. Yani kuna vitu zinatoka kwa masikio. Effusion of fluid in the middle ear without evidence of infection. Then you have, that is called, I've talked about middle ear effusion. So I'm talking about myringotomy, incision of the tympanic membrane, umetoboa, myringotomy. Then you have osiculoplasty. Osiculoplasty is a surgical reconstruction of the middle ear bones to restore hearing. Then ostalgia, that is ear pain, and nostalgia, right? The otitis externa, inflammation of the external auditory canal. Then otorrhea, drainage from the ear. Otosclerosis, a condition characterized by abnormal spongy bone formation around the steps. Then presbycusis, progressive hearing loss associated with aging. Ukizeeka unazidi usikii maneno, you like Otieno, and you're not even responding, or Uma, and you're silent, right? That's because you are 70 years or something sort. Because ango, what have you said? You like, who was taken porridge with this cup? Then you're like, what are you saying? I go outside. Yeah, so it's called the presbycusis. Yeah. Then you have the rhinorrhea, drainage from the nose. The ear comes in with its whole content, it drains from the nose instead. Then you have the sensorineural hearing loss of hearing due to damage of the organ of hearing or cranial nerve 8, or maybe both, damage and the head. Yeah. So that is that. So let's start with the review of anatomy and physiology of the ear. And please, if you are watching over in YouTube, don't forget to subscribe. Like medical students are right now, you're over 2,000, I think, almost 3,000, because 2,600. That is according to the data obtained from the database of your registration in MSA. But here, subscription to 1,000 is a disease because of laziness and ignorance. Kindly, wherever you are, just try and subscribe. I don't know if it will cost you. It will only cost your school Wi-Fi. So don't forget to subscribe, please. Just, that is the most key. Yeah? Good. Not that very key, actually, but yeah, just subscribe for benefit of doubt, or maybe just for the Christ's sake or her last sake, whatever. So let's review the anatomy and physiology of the ear. First is the organ of the hearing and balance, that is clear equilibrium setting. So it helps you to hear and also set your balance. Ukitolewa masikio hadi ile kitu ya ndani, utaanguka chini. The stability here, those higher receptors will be now. So except the pinna, which is this outside structure, the structure of the ear are within the protractor portion of the temporal bone. So apart from the pinna, which is outside, it is divided into 3 parts. The outer ear, I'm sure that one you talk about when in your high school form 4, consisting the outer ear. The outer ear is the auricle of the pinna and the external auditory canal that is still outside. And then you have the auricle, the expanded portion of projecting from the side of the ear, composed of the fibroelastic cartilage covered with skin. Then you have the lobule. The ear lobe is the soft palpable parts of the lower extremity. And then you have the external acoustic meters, is a slightly S-shaped tube about 2.5 centimeter long, extending from the auricle to the tympanic membrane, and it is also lined with skin containing hairs. Then later on we have the lateral third, has numerous sebaceous and cruminous gland. Cruminous or cereminous, whatever you call it. Yeah? These are just wax and sticky material that are found in the auditory canal. So cruminous glands secrete cerumen or carumen, whatever. the wax, sticky material containing lysozyme and immunoglobulin. And exams will come. What are the components of the Kiramen? And you're like, this one, somebody said lytic enzyme. No, it is a lysozyme and immunoglobulins. Both of them are just macrophagic in a way. They are defensive in immunia. Like lysozyme will produce a lytic enzyme to digest bacteria and so on. Then immunoglobulin will fight over any disease-causing microorganism in that region. Then let's check on the movements of the temporomandibular joint during chewing and speaking. Massage the cartilage. That one will help in massaging the cartilaginous meatus, moving the wax toward the exterior outside. That is movement of the temporomandibular during chewing and speaking. So another interesting part is the tympanic membrane, completely separating the external acoustic meatus from the middle ear. So it is the last point of external ear. It is always oval in shape with 3 layers: outer covering of airless skin, middle layer of the fibrous tissue, and inner lining mucous membrane. Normally it appears purely gray and translucent to some people. When you check it well, I know you guys have done this. Let's go to inner ear. Then a regular shape air-filled cavity, which even you can't draw it even if I gave you 10 days to draw it. So it is a regular shape air-filled cavity within the petrous portion of the temporal bone, and the middle wall is a thin layer of temporal bone with 2 openings, the round and oval window. And then the hair reaches the cavity through the osteochondral auditory. Through the osteochondral auditory tube, which is about 4 centimeters long and lined with ciliated epithelium. It connects the middle ear to the nasopharynx, which equalizes pressure on both sides of the membrane, because without that you'll feel like uski vizuri. The pressure, even if you're in a vehicle and then you got off blank off from the hearing perspective or perspectives, you're like, so what you need to do as a remedy, just yawn, and then after yawning your ears will resume their functions. So when the balance is between the external atmosphere and the inner ear is tampered with at most, we end up having problem with that. So it also drains the middle ear. In children, it's shorter and wider, thus making children more susceptible to middle ear infection. And it's also more easily blocked by allergies, enlarged adenoids, or inflammation of the nose and throats. The middle ear has 3 bones called ossicles. The malleus, the hammer-shaped. It handles, that is the malleus, it's always the hammer shape actually. I know we have the 3 bones which are malleus, incus, and stapes. So the malleus itself, the malleus, is a hammer shape. It handles, it's in contact with the tympanic membrane, and the head forms a movable joint with the incus. So it's like just the hammer here. And then the incus, the middle anvil-shaped bone. Bone is articulated to the malleus, and its long process is the step, so it's held to the wall of the cavity by its short process. Then the last one, which is stapes, it is the medial stirrup-shaped bone. Its head articulates with the incus, and its foot plate fits into the oval window. So inner ear is the last point of our review of anatomy of ear. It's normally filled with fluid. It's not filled like the middle ear. So fluid between the bony labyrinth and the membranous labyrinth is filled with the perilymph, and the membranous labyrinth is filled with the endolymph. And the vestibular is the expanded part of nearest the middle ear. It contains the oval and round window in the bony labyrinth, and the utricle and the circle in the membranous labyrinth. So the cochlear resembles a snail shell. It has a broad base, continuous with the vestibular and narrow apex. A cross section through shows the compartment, that is the scala, vestibular scala, tympani, and scala media or cochlear duct. So when you start with the scala vestibular, which originates at the oval window, and scala tympani end at the round window. So the cochlear duct has a supporting cell and specialized cochlear hair cells lying on the basilar membrane, and they contain auditory receptors that are connected to the trochanterial membrane, the tectorial membrane, and these cells form the spiral organ of Coti, which now detects and transmits impulses. Semicircular canals, there are 3, horseshoe-shaped, and lie in 3 planes of space. They contain hair-like nerve endings that are set in motion by the fluid in the canals, and they transmit information about the body's position or to the brain. So they are the ones which are responsible for what we call the equilibrium setup of your body. So look at this. That's an image. You're supposed to check it, interpret it, relate it with what we just learned. See what is the by divisions of the ears, the 3 main ones, the outer, the middle, the inner, and what they meant by all those structure which I was. The inner ear, these are the 3 stones, the malar, the inca, and the step, and how they look like. Still on the same images. can view that just directly is what I was saying. Yeah, so then from there, physiology of hearing is what I'll just grasp at very fast and then I change on. So first of all, sound waves reach the inner ear through 3 routes. One thing that you need to do is know that the sound will reach through 3 routes. 1, through the ossicular chain from the tympanic membrane to the oval window. 2, directly across the middle ear by means of airwaves. Or 3, bone transmission through the walls of the external auditory canal, the inner ear. So sound waves enter through the external auditory canals and they struck the tympanic membrane, which vibrates at various speed according to pitch. Ossicles in the middle here vibrate and transmit vibration to the oval window. Then later on, fluid in the cochlea is set in motion. Then wave-like motion of fluid passes the vibration onto the tiny hair-like nerve ending, the receptor in the organ of Cauti. And then the nerve ending stimulates are sent to the vestibular cochlear nerve and the temporal lobe of the cerebral cortex where sound is interpreted. Balance and equilibrium. Sense of static balance is done like this. When a person is at rest, is centered in the auricle and circle of the inner ear. Balance with the movement is associated with the semicircular canal. So balance will depend on receptor in the ear. That is the labyrinth vestibular system, tactile skin receptor, visual input like your eye seeing where you are lying, and then proprioceptors in muscles, sending information about equilibrium and balance to the brain, that is cerebella, for coordination and perception. Ndio maana ukilala ukienda kusinzia unastuka ghafla binvu. So from there we check on the history taking. And I just use this time to run on that. So history taking. First, anatologic history includes 1, demographic data. And when I say demographic data, it's just like the biodata which are used to the name, the sex, the occupation, the next of kin, the residence, the whatever. Chief complaints comes next. Hearing loss, that is a chief complaint. Pain, but you see, you don't say your things, you say what your patient tells you, right? You have to speak or you have to write them just the way they come from your patient's mouth. So pain, tinnitus, vertigo, dizziness, drainage, loss of balance, and they're supposed to be arranged. If there are more than one, you arrange them in the order from the first one to appear. Yeah. Then you need to determine them or analyze them based on the frequency, duration, how often, right? Mara ngapi kwa siku unasikia tinnitus? Masikio yako inakuuma mara ngapi ukiamka na ukilala? Sort of, those are questions. Onset, when did they start? Ilianza lini? Ilianza Friday, ikashinda hadi leo ama ilianza tena? You see, precipitating factor. Ukikula mayai inasimama. Ukilala inapoa. Ama ukilala inaongezeka. Ukimeza Panadol unasikiaje? Those are the questions you need to know and they should be on your fingertips, eh? Past medical history, childhood illness, check on otitis media in the childhood illness. Have you ever had otitis? Ushai kuwa na shida katikati ya masikio? Eardrum perforations, mumps, and eardrum perforation normally come with deafness circumstances, like a ski, if it's partial or complete deafness, I don't know. Then check on the mumps, eh? Yeah, when they have mumps, they are both the what we call the adenoids, all this, the tonsillitis. The mumps will present with a lot of malfunction and malformation like enlargement of lymph nodes, so on. So until they realize that it can also affect the ear through compressing and closing with it. So check on that. Check on measles as well. Check on meningitis, tonsillectomy, ear surgery if there is history of that. Then medication. Check on any example of phototoxicity drugs like aminoglycosides. They are very key in that. Quinine, if at all there was injection in quinine before, so that at least you can rule in, the tinnitus from the quinine. Chemotherapeutic agent, aspirin, can also cause tinnitus. Allergies, check on the allergies, right? Any allergy before, umekula ugali gani, ukikulanga hii nyama ya whatever, ya antelope, do you always have this kind of event happening to you, right? So that is that. You need to confirm allergies. Which food don't you use, or what allergy of food or drug or even drinks, which one do you have? Confirm. Family history of hearing loss, social, because some are genetic also, you have to also inquire from the history lineage. Social history, occupation, anafanya kazi, is he working where there is a lot of noise, and are they being provided with those earbuds? Check on the occupation. How long have you worked on that industry? And do you have this problem since you started working there, or it just came in as it's? Leisure activities. What do you like doing when you're free? Do you swim a lot? hobbies, swimming also, water can pee. Then on examination, you check on the physical examination, inspection and palpation is the first thing. Note size by using your eyes, configuration, inflammation, if there's any lumps or lesion or cyst. Palpate and manipulate pinna to detect tenderness, nodules or toffee, small hard nodules in the legs that are deposit of uric acid crystal characteristic of gout. Because if you have gout, direct observation, tip head slightly to the opposite side while pulling the pinna up so that you can see. So you push it opposite side, then you tail the inner pinna back and out, and then you'll be able to see. Use pen light to inspect canal for abnormality, excess wax, redness, scaliness, swelling, drainage and cyst, and then you write down what you're seeing. Assessment of the auditory system, otoscopy using otoscope. It's a light source and magnifying lens. Hold the otoscope in the right hand and grasp the auricle with opposite hand and gently pull outward to straighten the canal. Insert the speculum and observe. A normal tympanic membrane will appear gray and translucent. It is positioned obliquely at the base of the canal. And then you can use whisper test. In the whisper test, the examiner covers the untested ear while testing the other ear. Whisper softly from a distance of 1 to 2 feet from the unoccluded ear out of patient's sight. Patients with normal hearing can repeat what is whispered. Another test, the third test, is Weber test. It uses bone conduction to test literalization of the sound. A turning fork is set in motion by striking it and is placed on the patient's vertex or forehead. A patient with normal hearing hears the sound equally in both ears. In both ears, that is, I've said. If the ears are okay, the patient with good ears, he will be hearing in both ears, right? Or describe the sound as centered in the middle of the head. A patient with conductive hearing loss, on the other side, like if a case of otosclerosis, he will hear the sound better in the affected ear. So a patient with the sensorineural ear loss hears the sound better in the normal better hearing ear. It is useful in detecting unilateral hearing loss. That is that test. The fourth test is Ring test, useful for distinguishing between conductive and sensorineural hearing loss. A vibrating turning fork is again placed on the mastoid bone. Once the patient signals he does not hear the sound, the fork is put 2 inches in front of the ear. Normally, air conduction is audible longer than bone conduction. And so in conductive hearing loss, bone conducted sound is audible as long as or longer than air conducted sound. In sensorineural hearing loss, the air conducted sound is heard longer than the bone conducted sound. Audiometry is another test. It's the most important diagnostic tool. Types of audiometry, they are pure tone audiometry and speech audiometry. Only the two, pure tone audiometry and speech audiometry. For the pure tone audiometry, the sound stimulus consists of pure or muscular tone, but for the speech audiometry, ability to hear and discriminate sounds and words. That is, the louder the tone before the patient perceives it, and the greater the hearing loss. So, the patient wears earphones as signals when the tone is heard. When evaluating hearing, 3 characteristics are important. Characteristic number 1, frequency. Number 2, pitch. And the last one, intensity. I've said frequency, pitch, and intensity. Starting with the frequency, it refers to the number of sound waves produced per second. It is measured per cycle or hertz per second. A normal human ear perceives sound in frequency ranging from 20 to 200 hertz. Frequency from 500 to 200 hertz are important in understanding everyday speech and are referred to as speech range frequency. Right? I hope we are good up to there. And then when you talk about the pitch, I've said describe frequency of a tone. 100 hertz is considered low pitch and greater than 10,000 high pitch. So let's talk about intensity. How is intensity? Measures the loudness and sound in decibels. dB. It is the pressure exerted by sound. Hearing loss is measured in decibels, and sound louder than 80 decibels is perceived by the human ear as harsh and can damage the inner ear. The critical level of loudness is approximately 30 decibels. Testing detect vestibular condition. You'll have the Romberg test, caloric test, and so on. Let me check how far we are supposed. No, okay. So we'll do that test, then we'll leave at hearing loss. So next time we'll have our ENT at hearing loss. So test to detect the vestibular condition. Number 1 I've said is Romberg test. What is Romberg test? It is done to assess the inner ear for balance, and the client stand with the feet together, arms by the side and eye closed. Note the ability of the patient to maintain upright posture with only minimal amount of swaying. If the client closes balance, it is a positive Romberg, indicating vestibular problems. Caloric test is another test. For caloric test, it's used to determine if an alteration exists in the vestibular origin of the vestibulocochlear nerve, with the client either seated or supine, instill water into the external ear canal. Sometimes warm or cold water are alternated. Test the affected side first. Normal response to this is nystagmus, involuntary rapid rhythmic eye movement, feeling of failing, vertigo, feeling of spinning, nausea, and vomiting. Decrease or absence of the response within 3 minutes indicate abnormality. Contraindication to this test is if somebody has got perforated eardrum or infection of the middle ear. You should note that anticipate vomiting and provide an emesis basin. So juu unangojea anaweza tapika, mletee beseni ya kutapikia. Electronystagmography, the electronystagmography, what I told you, I hate pronouncing it. Electrodes are placed near the client's eyes to assess for alterations in the vestibular system. Then caloric test is performed. While eye movements are recorded on a graph, it assesses oculometer and vestibular system and their corresponding interactions. So the next lesson on ENT, we are going to have hearing loss as one of the main topic to start with. Thank you so much for presenting. For availing yourself. Do not forget to subscribe and share to your friend. Have a nice moment. Courtesy of Medical Students Arena and KMTC, Dr. Uma presenting.